Welcome everyone to this afternoon session on digitalizing palliative cancer care, opportunities for equitable and quality patient services. Thank you for joining us in the room and online for this really important topic. We hope to have an interactive session with Slido for those of you online and for those of you in the room who like to interact anonymously with the panel. But we will also have a roaming microphone throughout the session for those who want to pose questions here from the room. To begin, let me ask you, only unfortunately those of you who are in the room with us, a question. We're going to do it in a digital care session the analog way by raising hands. So how many of you associate palliative care with care in the last months or weeks of life? I think we have a good share of the people in the room who look at it that way. And it's a very crucial question for us. We'll hear from the panel in a minute how they reflect on that. Because obviously, depending on how you understand palliative care, the types of services and the approach you take and the extent to which and how digitalization can happen differs, right? So palliative care, if we look at different definitions, is an approach that aims to improve the quality of life of people dealing with serious illness and their care partners, address symptoms and ensure care is coordinated. This is one of the definitions. But if we look at the way that the WHO looks at it, there is a further specification that says it goes beyond physical symptoms, and this is quite important for what we're talking about here today. And it has to do with relieving serious health-related suffering, be that physical, psychological, social, or spiritual. We know that globally, this is again WHO data, about 14% of people who need palliative care services actually receive them. And if we think in particular about palliative cancer care, we have 22 estimates for EU member states that show us that about 30% of men and 25% of women will be diagnosed with cancer by the age of 75. So we clearly see that we have an increasing need of palliative care services and a base to build on that is not particularly stellar. So this is a point where we can ask ourselves, where can digitalization come in? What are the opportunities for us to improve in that area, and what are the areas where we need to be particularly careful with digitalization in this specific area of care? So we have a really stellar panel today with us to talk these elements through. Of course, we will discuss this in particular in relation to cancer care. I will introduce the panel. You see most of them sitting here in a row. And then we'll have a quick first chat around the group to set out the situation and the challenges, how we understand them. We'll come to you for your insights, for your questions, and then we'll think about actions for the future, where we want to go and how everyone can contribute to that objective. And we'll wrap up again with insights and inputs from you. So we have sitting around, well, in alphabetical order, the first person is not sitting around, is online, is Christina Dietscher, who is the head of Department for Non-Communicable Diseases, Mental Health and Geriatric Medicine at the Austrian Ministry of Health. We might see her briefly online. There she is. Hello, Christina. It's nice to see you. We have Elisabeth Kuiper, the Associate Director and Head of the Social Europe and Wellbeing Program at the European Policy Centre. So hello. We have Fiona Keeley, who is a palliative care doctor, researcher and consultant at the Marymount Hospice in Cork, Ireland, over there. We have Diana Nemes, who is a researcher at the Department of Public Health at, and I'm going to try this, I don't know if it's going to work, at Babeș-Bolyai University. Thank you, in Romania. And we have Tessa Richards, who is a patient advocate and associate editor with the British Medical Journal. So really a very well put together group of people to discuss this question, and even more well put together with all of you around here in the room and online. We start, Tessa, perhaps with you, with your reflections and your experience from your patient journey and where we are now with palliative care.
Well, thank you, Dimi. Back in the day, I used to come to Gastein to report back on events for the BMJ, but today I've been asked to give a personal perspective of what it's like to live a long time with an incurable progressive cancer. 20 years ago, I was diagnosed with adrenal cancer, and it's incredibly rare. About 1 in 2 people per million get it, and the 5-year survival rates are very dismal. I was diagnosed late, and I went under emergency surgery to remove a 20-centimetre tumour that had started to invade the local tissues. Unsurprisingly, within a year, it had spread to the liver. So I had another round of heroic surgery to remove the metastases, the spread in the liver, and I had a kidney and various other bits and pieces taken out too. Then high-dose abdominal radiotherapy. My long hospital stays on intensive care and high dependency wards still haunt me. I'm pretty phobic about going into hospital. But I had to. 3 years later, I'd got metastases in the lung. More thoracic surgery was recommended. Well, sorry, I hadn't had it first time. It was this, you know, we should do it now. And I was really skeptical, not just because I didn't think I could face it, but also because I knew of evidence from that when a cancer has spread from the abdomen up into the lungs, the outlook is very poor. And it may not be sort of ethical or possibly cost-effective to take the metastases out of the lung on a patient with disseminated cancer. So this was a quandary. And I took soundings from other people. And of course, I went online because it was possible then. I didn't really do it, you know, at the early stages. I'm not sure how possible it was. And I met a man online. His name was Troy Richards, and I'm Tessa Richards. That's a coincidence. And what was the biggest coincidence was that he also had adrenal cortical carcinoma, and his disease trajectory had been very similar to mine, but he'd been a lot more proactive. He'd funded a research centre into this rare cancer, and it set up a patient community which linked patients round the world to exchange information, advice, support each other, flag where the centres of expertise were. There aren't many, about 2, and just generally share information which a lot of doctors don't have about where there is good new research and clinical trials ongoing. Anyway, Troy styles himself as or did then, as a 3-operation, 9-year survivor. And he said, go for it, girl. So, you know, I did. And that was a good move, because I had a few years before the cancer came back in the liver. Well, at the root, at the back of the liver, it was completely inaccessible, and the doctors looked pretty grave because they didn't know what to do. I had more radiotherapy, and they then offered me a positive smorgasbord of treatment options, okay? More risky surgery, chemotherapy, mitotane, going on a repurposed drug or a clinical trial. So I did a lot more Googling, and none of those options promised much, and I knew they would erode the quality of life, and I've always valued that more than its length. I asked them, what would happen if I do nothing? The consultant was clearly uncomfortable with that question, but he did tell me the next likely thing was intractable pain from invasion of a group of nerves that sit right there in the middle of your upper abdomen. I asked to go and see a palliative care doctor who listened, asked me if I had religious beliefs, but concluded that I wasn't a candidate for palliative care. I then went online and shared my history with some centres outside the UK with some expertise. And one said, my goodness, haven't you been offered nanoknife? I said, no, what's that? So explained that it was a non-thermal form of ablation, and it was used, and in fact, it'd been pioneered in a hospital down the road from mine to treat patients with inoperable pancreatic cancer, which in many ways is what mine resembles. It has its problems. It's not risk-free. You've got, you know, immediate, pretty tough short-term effects, and I have to self-fund it because it's not approved for my rare cancer, but it's given me a good quality of life. But things now have moved on. My abdominal metastases, tumour is growing quite rapidly, and there's a 5th round of nanoknife suggested, and I dread it. I wonder if it's actually ethically right to undergo it. So many don't get effective care, and I'm older and a little bit more weary of this journey. I know I can't beat my cancer, and I don't really like that rhetoric much. I can't beat it any more than I can beat the 3 other long-term conditions I live with. My ambition is to achieve a good death. Of course, views on this vary. I read an article the other day which said the best way to die is being shot by a jealous lover when you're 84. Well, dream on. I just want to spare my children the harrowing experience I had of watching my brilliant 96-year-old mother suffer, lose her autonomy and dignity, and die a long, slow death from advanced frailty, having had a palliative care intervention for cancer at 96. As I say, she died of 98 at advanced frailty. I muse on how I can reduce the chance of this happening to me. And I also muse on what my cancer's journey has taught me. There's lots of things, but among them are the drivers of high-cost, high-tech cancer aimed to prolong life, almost seemingly at any expense, and it's fueled by professional and commercial vested interests. And by contrast, the vast number of people who live with multiple other debilitating long-term conditions get less support. There is a lack of transparency about the fact that the promising new drugs and treatments that get approved are approved and used on the basis of surrogate outcomes like progression-free survival, not quality of life and overall survival. I'm angry that despite the importance of informed shared decision-making and the commitment to it, so many recommendations about treatment in cancer care are made by multidisciplinary teams in meetings from which patients are excluded. I am truly dispirited by the fact that I have no trusting relationship with the doctors in my tertiary care hospital, who I meet in the clinic or in short calls over the phone. For a therapeutic relationship with a doctor who you trust is worth rubies. I observe a pressured system where everyone is under stress and new technologies don't seem to be helping much. As a patient, I feel more processed than cared for.
Thank you, Tessa, very, very much for sharing this with us, and I think putting very well into perspective where we are failing our aspirations for care that is actually patient-centered and tries to really, with the patient involved, improve quality of life. At least that's part of the really important message that I hear here. And we come back to you in a second for more reflections. Fiona, I come to you. You work as a palliative care physician, right? So maybe you can, or palliative care doctor, right? You can reflect a bit on what you heard and what you see in your everyday work.
Okay. So I might start talking about my type of work with a quote from, I don't know if any of you are familiar with Dame Cicely Saunders, but she would have been the founder of the modern hospice movement in the UK in the 1960s. And, you know, a very kind of powerful statement that she made was, you matter because you are you, and you matter all of the days of your life. And that is actually remaining very much a beacon, a principle for any healthcare professional working in palliative care. It's kind of our North Star. It speaks to a brave practice of being present as a healthcare professional when one cannot necessarily solve, to the practice of non-abandonment medicine and an ambition to proactively mitigate and sometimes prevent avoidable suffering that can accompany living with serious illnesses. We can't get rid of, there are some unavoidable sufferings around loss, that's just hard, but there are things that can be done and can be impacted to improve people's quality of life. I think it's important to remember, as we talk about digitalisation of this space, is that medicine itself is first and foremost a social endeavour. It's for people, it's by people, it's about people. And nowhere is that more obvious in palliative care contexts where the stakes are actually really high for people. They tend to be time-bound. There is often circumstances where there is one chance to get things as right as possible. There isn't time for do-overs. So experimenting on things with people with palliative care diagnoses, we need to be very careful ethically around how we approach that. And then as a healthcare professional in this area, I understand and deeply value, and as Tessa has mentioned as well, that therapeutic relationship between healthcare professional and patient is the primary enabler for me to deal with work that is complex, technically, logistically, ethically, and relationally. And this relationship, for the healthcare professional, we have to make that iterative. It has to evolve. It has to be evidence-based, and yet it has to be vulnerable in and around the same time, because our patients' needs are changing over time. Their values and preferences will change over time, and we are encountering new phenotypes of palliative cancer patients, like Tessa has described, who are living long-term with serious illnesses. They're piggybacking from one treatment onto the next. They're accumulating morbidities and toxicities from those treatments, but unique to curative intent cancer patients per se, their background disease is also progressing, further compounding and adding to that. They are bombarded with appointments, high-tech treatments. They're very, very busy people, but largely the work of what they do and how they deal with their illness is a personal piece, and it plays out primarily in people's own homes. So we need to remember that as we look to talk about digitalising this really human space. There are three relevant kind of supply and demand knowns that are framing digital palliative care currently, to my mind, and certainly in my practice. Dimitri, you mentioned some of them on your initial introduction, but we know that timely, early integration and better access to specialist palliative care leads to better outcomes for patients and also their carers, also improves their satisfaction rates. But we are dealing with a healthcare professional shortage, and a small, finite specialist palliative care resource is colliding now with population growth. In Ireland alone, we've done some modelling up to 2046, and we know in that time the prevalence of palliative care need in Ireland is going to double. And not only that, but the numbers of people who die from a diagnosis with a palliative care need is going to rise by 89%. There is also, unfortunately, a false assumption built into our health systems in that palliative care for all and palliative care is everyone's business. This isn't actually happening on the ground. For example, it is not mandated that undergraduate medical schools teach their trainees in palliative care competencies, palliative care needs assessments. We have done surveys in Ireland of our junior doctors in the acute hospitals, which is where most people worldwide tend to die, and 25% of those junior doctors screen positive for post-traumatic stress disorder on the back of their experiences of being involved in the delivery of end-of-life care in hospital settings. Most people, as Tessa sort of began to talk about as well, wish to be at home. But when you're at home, a lot of time is spent out of hours. If you think about it, 2/3 of all time is out of hours. And we don't have services in place to respond kind of in a timely fashion to patients with complex needs in that regard. And so it's into this murky context, and that's why I bring it out, that we bring a conversation then around a very human experience in a very human space that is palliative care. And we need to understand that, and we need to understand that what palliative care healthcare physicians do, it's a high-touch specialty. It's not a quick in, a quick out, we'll see you in 10 minutes and sort it out. There are very deep existential issues. There are very technical things around complex pain and symptom management and holistic care that need to be addressed. So what we set out to do with our research, which was very kindly funded by MSD, was to just bite off a small part of this. It's not going to tackle everything, but we were interested in the adoption of telehealth from the patient perspective and the healthcare perspective. Because certainly in the wake of the COVID-19 pandemic, there was an utter explosion in this, and a lot of these things were deployed in an emergency basis, but without the usual behaviour change models of care to support them. So going to the patients firstly and looking at the literature there, telehealth in general, particularly teleconsultations, and that doesn't surprise us when we realise about the human nature of what we do in palliative care, are broadly acceptable, actually, to patients with advanced cancer with palliative care needs, but with certain caveats at certain points of stability and other inflections along their trajectories. It's convenient, gives them a sense of autonomy, they feel a bit more in control, and it adds a layer of security that they know they can contact their healthcare provider when it works for them. But we also know that data on engagement with telehealth adoption is waning, particularly from the healthcare professional perspective. So then we delved into that and we had a look at that. Well, what are the behavioural intentions of healthcare professionals in Ireland around the ongoing adoption of telehealth in the post-pandemic phase? And we use various models to kind of, elucidate that. And what we found is that, again, overall here, healthcare professionals find it will improve the performance of their job. And we are real pioneers around this. We feel really strongly around this. We will not engage in stuff that does not help us help our patients. So that's a very strong finding. However, 2/3 would say that they have never experienced a situation where they haven't had very frequent technical difficulties. So that's a real barrier to them actually using it. Another really important barrier: insufficient training, insufficient organisational support, and social influence features quite prominently, actually. So if your peers, if your digital champions are not surrounding you to support you in this work as a healthcare professional, teleconsultations and tele-enabled care is simply not going to work.
Thank you very much, Fiona. I think this is really useful touches on a range of really key issues. Tessa, I'd like to come back to you, if that's okay, for a reflection, because you heard about some of the findings of how it might be useful for telehealth in particular. Is that an experience you made, or that you would have considered a positive add-on to the experience that you had, potentially?
Well,
Microphone?
I mean, in some ways, I can see advantages. If I could be fully connected at home with support to a central hub that somehow had some magic way of knowing what was going on at home and how my carer was coping and if they were coping. And I had a great chat with a friend who nursed his young dying fiancé at home, and he said, the trouble, the monitoring's okay, you can get this. But then what happens when the monitor breaks, when I can't really understand the monitor, it's doing something funny, when the catheter gets blocked, when the emergency button doesn't work and actually there isn't anyone at the end of the line, there's a hotline, but it's not hot at the moment. My wife is choking, and I don't quite know what to do, and she's suddenly gone blue. I mean, there are all sorts of things that are really hard to cope with, as you well know. So I think there are real problems about how you make it work at home. And the one thing I think we're a bit blind about is we sort of kind of know what's likely to happen to the patient, but the likely things, we see patients in hospitals, we see the palliative care sort of flow, but I don't think we know nearly enough about the burden on the carers, which I think is immense. I mean, I've just, my sister's gone through a terrible time with her husband who died from cancer, and I just think, does anyone gone around and had a chat with her and said, what was it like? What would have made a difference? What would have made this awful experience easier for you? What support would you have liked? And, maybe we can use carer feedback more than we do. We talk an awful lot about patient experience data, don't we? And I think that's fabulously important. But I think, we've got a bit of a blind spot and we need to do more on the carers level.
Absolutely, and thank you, Tess. I think you are in part also doing my job for me, because I think the next point that we wanted to hear from was Diana, and Diana, you're doing work exactly on the carers issue in this field. So give us some of your insights from this.
Yeah.
What is the evidence, as Tessa said?
Sure. So for sure, many points taken by Tessa and Fiona actually reflect many of the challenges that the patients and their caregivers, and by caregivers I'm referring to the informal ones, so the family members or someone close to the patient, face when trying to navigate the palliative care system. And drawing on Romania's situation, there are definitely key gaps that need to be addressed in order to actually promote an equitable, access to these services. But let me start by saying that there is no coherent nationwide framework to start with that actually ensures the access for patient to these palliative care services. Indeed, the national beating cancer plan from 2022 to 2027 actually takes some steps towards an integrating system for palliative care services with the help of the digital tools. But what can I say is that the clock is ticking. So yeah, I was mentioning earlier about some key gaps that need to be addressed, and one of the most pressuring issue is the health and digital literacy of the patients and their caregivers, because research constantly shows that they are like struggling to understand what this digital word means, let alone use it so in a manifest way that actually helps them. So this is what we talked, and we actually focused more on the underserved areas, because digitalization, maybe in urban areas they are easier to reach, but what about the rural ones? So we know for sure that in Romania there are fairly large areas where non-medical infrastructure is available, or even if it's very weak. So just imagine that no medical aid can be available for you in your neighborhood. So this is how we actually started to see, okay, what can be done? And we started talking with NGOs fighting for with cancer patients' rights, patient advocates, and this is how we actually identified this missed opportunity in palliative care. So using the caregiver as their literacy to actually help in this process. And okay, how can we actually help them? Because at the end of the day, they are not like health providers. They are still human beings trying to help someone close to them in need. So yeah, what to do next? And what we found out is that they need the help from someone close to them. I'm speaking about remote areas. So who are the ones that are really close to them and are actually health providers? So the community health workers. So this is what I'm trying to build upon that. But probably we will discuss this a bit later, but in actionable policy opportunities. So yeah, we are just taking the caregiver, actually identifying it with, in this ecosystem of patient, and actually let's unite those forces and help the support system that they need.
And this is both for working with the caregivers to support the patients, but also for supporting the caregivers themselves.
Of course, because it's really hard managing all this, clinical, emotional, social part of being a caregiver.
Yes, and on top of that, the digital literacy that is necessary.
Of course,
if the way that you're thinking about bridging the gap in other services is a digital service, on top of all this really challenging situation, you're putting an additional task. And so this is something to really carefully.
Of course, they can bridge the gap, but they need the help to
really carefully think through. Fiona, does that reflect what you see in your practice?
Absolutely. I mean, a lot of our patients go on to develop degrees of frailty. They may have cognitive impairment, brain fog from multiple rounds of treatment. Fatigue is a really common symptom that patients experience, so their ability to focus and concentrate. And there's a different kind of concentration that's required for a telehealth conversation to an in-person conversation. So we sort of incorporated an ask that people would be accompanied to their online or teleconsultation visits with someone important to them that they will feel comfortable with as a second pair of listening ears, if you like, for support to help manage things technically if that's the case as well. And I think the other thing that we need to realise is kind of the feminization of caring in general, and that has implications for this. It has implications, and particularly as people approach the end of their life, it is primarily women who are providing the unpaid care in homes. And when you look also then at palliative care, healthcare professionals, it is a largely feminized specialty as well. So in our practice, about 80% of the healthcare professionals delivering palliative care are female.
Yes, and I think I wanted to ask, and perhaps then I will come briefly to Tessa before going to Christina, who is online waiting for us. Because you mentioned the post-traumatic stress that a lot of health professionals experience. And I wonder, for me, we're talking about primarily figuring out ways to do it better for patients, figuring out ways for doing it better for caregivers, but also figuring out ways to do it better for caregivers who are the health professionals providing care. So not the informal caregivers, but the actual health professionals, right? So is that something then where we should also be thinking about digitalization? Yeah.
Absolutely. I mean, well mother, well baby, well doctor, well patient. So if you have a traumatized or burnt out healthcare professional looking after you, they're not going to affect the best outcomes for you as a patient. So it's a real priority to start looking at, and the best way to prevent burnout is to improve and increase people's competencies. So that is within reach. There are, and I can talk to some kind of initiatives that I've been involved in and starting in Ireland to kind of start to address that later on.
Yes, keep that for the second part. Tess, I don't know if you have any reflections, because I think we're already collecting for Christina, who will come in with a policy perspective in a second, quite a range of different things that need to be rethought. Right? So I don't know if you would like to add something to that list.
Well, I'd quite just like to say that it's this great emphasis on increasing the literacy of patients and their carers. Let's think about increasing the literacy of the health system and the providers. They need death literacy too. And you've touched on this, that we've got far too many healthcare professionals who really have no competence and no confidence to discuss the realities of palliative and end-of-life care. And when it comes to technologies, I think it's extraordinary that anyone should impose a technology on a patient just on the grounds that, well, it's safe and it probably might help, without actually some requirement for proof that it actually is going to, improve outcomes, improve quality of life, save the service money, make doctors less stressed and open to burnout. I just wonder where we're going with some of this, because, it sounds almost like it's a bit like putting a new cancer drug on the market, and I've already mentioned the limitations and the problems with that. So lots of challenges.
Definitely, and I see Fiona has the microphone. Very briefly before we go to Christina.
Yep, so there's a newly published study coming out of the United States now, where they have actually done a randomised control trial looking at telehealth in ambulatory cancer patients versus usual care, face-to-face care, and it is as effective, it is as safe. So we're starting to get proper data coming out to kind of I suppose add some assurances, Tessa, around those really real concerns for sure.
Yeah. And I think it's equally important, as you both point out, to focus on generating this data and sort of put that in context with the hype of having a potential to help. I think we come back to that in the second part. Christina, you've been waiting long enough and without the pleasure of being in the room with us. Unfortunately, we blame the trains. We come to you for a policy perspective. You've been listening for a while, so give us your reflections.
Yeah, thank you. I'm sorry that I thought I would be with you today in person. When I listened to you before, I think that the very existential points that were raised and the very personal and human aspects, in contrast to that, the perspective of health policy is rather dry and bureaucratic in a certain way. But still, it's necessary to accommodate all the needs that we heard about before. We have to make sure that the patient needs are addressed, the quality of life issues are addressed, that the carer issues are addressed, and that the medical, the healthcare provider needs are addressed. What we do in Austria, for example, to do that is we have a National Cancer Framework Program, which is developed in a participatory way together with stakeholder representatives from these groups to make sure that their perspectives are well represented in our policies and in the infrastructures that we provide to ensure that everybody receives the right care and services, hopefully. I strongly believe that participation is important to improve the healthcare system because we have to listen to each other and to see what everybody can bring in so as to make the system patient-centered and really make it fit the needs of the patients. Also, I heard you talk about health literacy, which we also consider very important from a healthcare systems and services perspective. Of course, there is individual population and patient health literacy, but when it comes to service provision, there is a lot about organizational health literacy, systems health literacy, and doctors' health literacy, which we try to foster as well. So these are some of the important topics that we want to cover in Austria. And I think also not only the medical needs are of importance, but also the non-medical needs when it comes to palliative care, like, for example, mental health needs, but also questions of, for example, unemployment or getting the right devices that you need for support and things like that. So all the service providers, all the providers need to cooperate. It's not only hospitals, it's ambulatory care, it's family doctors, it's the payers' health insurance. There needs to be clear guidelines for the patient journey throughout that, and this is what we have to ensure. And of course, we look before we set out to define those journeys or those pathways, we have to see what are the actual needs. And for that, data is very important, as was also mentioned before. And of course, the evidence is important. And evidence, again, is something that brings in the different perspectives, because evidence is not only scientific evidence, it's also medical experience and patient preferences. And this is what we need to bring together in policy frameworks.
Thank you very much. I think it's encouraging that the awareness, at least in the Austrian setting, is translated into at least policy intent. Let's put it that way. I think, Christina, I like the way how you highlighted the different levels of literacy. I think it echoes very well what colleagues have been saying on the panel. And I think, in a way, if I may put it simplistically, the participation element that you highlighted in the very beginning might be a way to increase the literacy of the system when we're thinking about really delivering patient-centered care. Right, so this is something where I think that the coordinated approach for looking at it might come in. So thank you very much for this. We will bring you back a bit for your wisdom on hands-on approaches in the second part when we've heard from our audience as well. I link to one of the things that Christina said to come to you, Elizabeth, about the issue of data and evidence. You've been also hearing from everyone the different perspectives. You have more the international perspective. So I don't know if you want to come in with some initial reflections and then we can build on that.
Well, thanks, Dimia. Thanks to all of you. I really feel quite humbled to be in this panel with such personal experiences by Tessa, but also by you, Fiona, as a healthcare professional. And I can only say that indeed, as the daughter of a mother that has cancer, indeed, health policy should never be a goal in itself. It should always be about the patient. And therefore, terms as health literacy and communications are used very easily without always being thought through what it really means on a practical perspective. Because especially indeed in a time of technological change, where indeed we all have our smartphones, we use data, I think it's even more important to really explain to people what it means, what happens with our data, how they can actually access their data. And I think especially when it comes also to the intergenerational challenges that we deal with. I mean, looking at my mother, she's not from the generation that's born with a smartphone in her hand. So if you one day just get an email saying that you should look in your e-health file for your latest results without any explanation by a healthcare professional, what are you supposed to do? How are you supposed to interpret all of that? And I'm saying that as a bridge to what you asked me about, indeed, European developments, because I think it's really important also at EU level to acknowledge that, because there's now a lot of talk about the fact that we have the European Health Union. And if I read the mission letter to the new health commissioner, elect, because he needs to still go and survive a hearing later in November, but that letter to the new commissioner stipulates that he needs to complete the European Health Union. And I think that's a very interesting phrase, because I think for me, how I see it, the European Health Union never really was a strategy. It's building blocks, and it's important building blocks, because especially due to the pandemic, of course, more competences were needed, for example, for the Center for Disease Control, for the European Medicines Agency. We already had the cancer plan, and I think the cancer plan is another important instrument also when it comes to indeed digital tools such as early detection, diagnose, treatment options. We have the European Health Data Space, which is another important part of the European Health Union. But again, all of this should be accompanied by a vision on how that benefits the patient, really. And I think that discussion sometimes is missing in Brussels. Also sometimes with the sort of the policy excitement about the fact that, yes, there is a lot happening. And I think a lot of important developments are happening. Also, I think from a public-private perspective, I think we see a lot of also important research collaboration happening in the context of Horizon Europe. But I think it should come indeed with recommendations where indeed people get concrete guidance about how to go about digital tools and their data. So for that reason, at the European Policy Center, which is a Brussels-based think tank where I'm working, we put together recent publications with recommendations that I believe are also useful in the context of this discussion. And what we said is, first of all, the EU needs to think about how to implement the European Health Data Space. Because as much as it was important that the Belgian presidency managed to reach an agreement on the European Health Data Space, there have been too limited discussion about how to implement this at national level. And after all, we know that healthcare systems are very different in form and shape. So the hardest part of this piece of legislation is still needed to be overcome at national level. And I think there the discussions about indeed how in a national context patients can use their data and how national agencies are going to deal with this, I think is a very important discussion. Also, and again that links also to broader developments that we may want to touch on if time allows, the European Health Data Space is the first of many more data spaces to come. We will have data spaces related to skills, to agriculture, to energy, even to tourism, so to very different sectors. And I believe at EU level, I have seen too little introspection about how these negotiations on the European Health Data Space went. For example, consent of patients. There has been discussion. I know that a lot of stakeholders in Brussels have written letters and statements on the topics. But is it really thought through, and can we learn from it also for the other data spaces? I think that's a very important notion to further reflect on. For the sake of time, because I think we had 7 recommendations that I can perhaps mention later on, indeed, we also said invest in digital literacy, not just of the patient, but also, Tessa, as you said, at a system level. Because also at a system level, we see that healthcare professionals, and you made that point, Fiona, are not really ready, because during their education, they don't really get communications around the use of data. So lifelong learning, which is another buzzword at European level, is something that also should be applied to these areas. The last one, invest in a digital and health infrastructure at member state level. And again, that's a very different part. But in the point in time where also cybersecurity is a real concern, and we have already seen threats to hospitals, how can you trust in data if perhaps these data are not even sure? And if they're not being treated in a secure environment. So again, these are rather meta-reflections if you link that to what Tessa and Fiona have been saying. But I think at the European level, these are important. And more than we do now, I think, should be linked to the patient's perspective, to not just see it as a goal in itself, but really see what more concretely can be done at EU level. And not too easily saying that that's not a competence that the EU has or hasn't, but really thinking on how countries can learn from each other in this context.
Thank you. I see Tessa with a microphone, so go ahead.
Yes, it's fascinating, the discussion around health data. And I just want to come just back a couple of steps. So what data is it, okay? It's the data in your health record, okay? It's your electronic health record. These are an absolute shambles in most places. They're not joined up, they're not interoperable, and I think we've absolutely got to prioritize making these fit for purpose. And patients got to have real-time access to full records. And interestingly, when they do, 1 in 5 find errors and omissions in them. Now, how can you have good patient care if even your basic digital tool is no good? And the other thing I think is not given enough attention is that, okay, let's raise everybody's health literacy. Well, how can you manage your bank finances if you don't have access to your bank statement? Well, I would argue that you can't self-manage your condition, and you do have to do it most of the time because you only see a doctor for 15 minutes, maybe, or on a phone, once every 3 months, perhaps. At least that's been my experience. I need access to that data to help me self-manage and to promote my own literacy. I can look words up, I can remind myself what happened. I could, if they were interactive, I could write an agenda for discussion in advance in my notes, which the doctor could read and say, good heavens, you've been admitted to accident and emergency 3 times since I last saw you. And you'd know what the patient was, their agenda is. What's in the notes, what gets recorded in a consultation every 3 months is what the doctor thinks is important, not what the patient thinks is important. There's so many more things we could do with really creative, new style electronic health records, I think, and some places are doing it anyway. I better shut up for now, because I could tell you about them. Send you a reference.
Yes, please do. And I think I'd like to build on that for a second before I go to Arjanga Steiner for a sense of what is happening on Slido, because this dimension of co-creation that we were talking about as a way for improving the literacy of the system. I don't know, Elizabeth, if you have a sense of how much of the process within the European health data space was with proper patient involvement and how much of not with letters sent by patient organizations, but by actually thinking through together with patients what we should be striving for, and how much of the implementation that we're looking at incorporates that, because what Tessa was just talking about would be invaluable to make sure that, especially in the area of palliative care, we're doing it in a way that is patient-centered, basically.
Well, I don't believe that patients have been fully involved. I mean, as you say, yes, they have been involved perhaps in the process as such, and I'm sure that indeed member states may have been listening on an individual basis to patients. But again, in the process as such, that there's not involvement. And I think that's not the first time. I still remembered when I worked for the Dutch government and I was involved in negotiations on the clinical trials directive. Of course, there was talk about one patient representative at the level of the European Medicines Agency. But especially if you think about the implications of specific diseases for different patients, how can one person represent a variety of disease areas? So again, I think it's really time that we think this through more properly, especially going forward, because again, with an aging population, we will have these instances much more often.
Thank you. And I think for palliative care specifically, and it echoes a bit what Fiona was saying before and what Diana mentioned, this understanding, going back to the initial discussion of going beyond the need for to addressing the physical symptoms, but also thinking about the psychological element, the mental health element, the social element, the spiritual element, not all of that is captured in the electronic health record, right? So when we think about digitalization in the area of palliative care, of course, that is the absolute prerequisite, but then there's additional layers that we need to think about and we need to figure out how to bring them in if we really want to be successful. So for that, I'm giving you all homework for the second round because we need to think about what the actionable points are. Before that, let's go to Laura. Laura is Arjanga Steiner, who's keeping an eye on Slido. Give us the highlights, or basically the themes that you see online.
Yes, thank you very much, Dimitra. So online there are several comments supporting the notion of putting the patient back at the center and the focus on quality of life rather than on progression-free survival. And the shift that we're seeing in medicines towards living with cancer rather than just treatment. And on that line, there's 2 questions that can follow up. How can we ensure that the patient voices are heard in palliative care policies? And probably following up on that, are the digital tools an efficient way to use the limited resources that exist on this field, especially consider that palliative care is, in palliative care we need such a personal component.
Okay, so I think let's tackle perhaps the more controversial one at the moment, because how do we ensure that patient voice is heard? I think we all agree. We put it in the second round in the actionable points. The second question was, are we sure that digitalization is the way to go in this area, right? So I wonder, for colleagues on the panel, first reactions in that direction. Tessa, I see you assertively picking up the microphone, so go first.
Well, I just wonder if the healthcare professionals, the policymakers, really understand that there's a parallel universe out there. And it's patients who are talking to patients in network communities. And they know precisely how to reach each other and reach the hard-to-reach groups. I mean, we don't talk much about patient leadership, do we? And we should. Because I think that if you want to get them around the table, just ask the patient leaders, ask the patient advocates who really are connected. It is very hard for an unschooled patient to be, who's not well, to be wheeled in and said, give us your views, what's important? We could do a lot better. In the UK, we've experimented with, with putting paid patient directors in NHS trusts and paid directors of patient experience. And I think this is what you've got to do. You've got to make this sort of the patient's perspective not be a kind of tokenistic add-on. It's got to be seen as collecting all this data and recording it and collating it and use it. I mean, that data is as important and valuable as medical data and should be there to help inform policy change, I think. And I also think that, anyway, I think perhaps I should stop talking.
For now, we come back to you in a moment. Fiona, I see you're getting ready.
Yeah, so in Ireland, I guess we enjoy a fairly kind of a maturity around palliative care service delivery. The hospice I work in is 154 years old now, delivering care, and it has kind of gone through many different changes over the years. We have a national adult and children's palliative care policy, and that undergoes kind of extensive public engagement, patient engagement, as well as healthcare professional engagement and governmental engagement to pull together sort of kind of policy priorities. And our new one has just been recently published just last week in that regard. Other issues like that kind of go to citizen assemblies, which feed into kind of policy making as well. So we also have a national clinical lead for palliative care who's actually a clinician who works in conjunction with our health service executive, and that is underpinned and supported then by a clinical advisory group which consisting of all the palliative care consultants in Ireland. So we bring those perspectives, and patients also trust us to advocate for them on their behalf through that particular fora as well. So there are different fora that are possible to create to feed into and up into policy at a systematic level.
Yes, I think we are answering the question on the making sure the patient voice is heard. After all, I think this is really important. Christina, before I come to you on your reflection on how successful perhaps that's been in Austria, Fiona, Tessa at some point mentioned shared decision-making, because I think you just mentioned the more high-level way of engaging patients. But is shared decision-making a lived experience for you in your everyday work?
Oh, absolutely. There is nothing. I mean, patients have a mantra that nothing about us without us. And we live very much by that. I mean, our decision-making can't work without the whole raison d'etre is for patient care. So without them inputting into shared decision-making, it just doesn't work.
I ask because I think that's not the case everywhere, right? So this is why if there's good practice to learn from, it's a really important point to put on the table. Tessa, before we go to Christina.
I'm sorry, I get very frustrated about shared decision-making. I've already alluded to the fact that you have teams who don't know you, don't know your preferences and priorities, don't know your other clinical conditions, and they're making decisions and they've got no responsibility for your ongoing care. They're not sharing them with you. And when you go to see a doctor and they say, oh my goodness, you've got X, Y, Z, and you're just reeling and trying to take in that, you've got this condition. And then they say, but what we think is you should have Y treatment. And, it's a bit this and it's a bit that. And they give you a brief run through of the side effects, pros and cons or whatever. But you can't really even concentrate to the inadequate information that they've given you because you're still trying to process, what's actually going on in your body. Now, if you would then say, oh, yes, doctor, that's right, that's not informed shared decision-making, but you can make it better. You could say, give patients at the end of consultations an online resource which gives them full information so they really can understand the risks, benefits and the side effects. And when they go for interventions, that they, instead of having, I've had a situation where people along and said, well, you know, we're going to carry out this, that, and the other. Well, can you sign this consent form? And you look at it, and it said, you know, you may die, you may this, what, the other, and you know, just sign here. You know, we can do better than that. I don't think we're at all good at, we share decisions, but they're not informed enough. And I think we've got to get better. And we could do this online and give patients adequate information and then let them come back and ask the questions they have. But to try to make them do it in a short frame of time, I think is unfair and pretty unethical, actually, because a lot of the treatments cancer patients are not very effective and quite toxic, and they really need to understand, you know, what the benefits and the risks are. And nobody ever asks the question, what happens if I do nothing enough?
Mm-hmm. Yeah. And I think that kind of speaks a little bit to maybe your oncology experience, whereas the palliative care experience can be slightly different. So we do micro and kind of regular follow-ups with patients around key decisions like that. We don't deliver the chemotherapy, that sits with the oncology team, but we kind of support conversations around prioritization of goals, ceilings of care, and we have sections in our assessments for your values, your preferences, what are you likely to gain from this, and we revisit it. We realise it's an iterative, changing situation. It's never once-off conversation.
Thank you. Diana, yes.
I just wanted to add that as we are talking about the shared decision-making, I think the governments are many times biased, that they think they know what the population needs. So we kind of have these issues with needs assessment and evaluation of the programs, because, okay, you actually building a program, but did you actually think about any, I don't know, indicators to evaluate it? I mean, since the, you know, scholar system, we think that evaluation is something that, you know, shows up something that is bad, but no, actually shows up what you need to work more on. So I think if we should see the situation like this.
Yeah. I see Christina is trying to raise her hand, and I promised I would go to her, and we just heard that sometimes governments think they know. So Christina, over to you. Do governments think they know while they don't know, in fact?
Well, I mean, refrain from interfering in medical decisions, actually. I do get an echo. I hope you hear me all right.
It's okay. It's not perfect, but it's okay. Go ahead.
Good. Well, now I lost my thread because of this echo. I'm sorry. It's not good for concentration. But what I meant to say is that this aspect of knowing, one of the points behind are sometimes legal issues. Doctors are afraid of getting things wrong and being sued afterwards because something happens. So we really have to work on a culture of trust in all sides. The patients need to have trust in the doctors, but also the other way around. So if you want to have trustful palliative care, we have to address these issues. And also talking about this and building trustful relationships is so really about going into emotions and allowing oneself to be touched by emotions on a deep human level, so to say, and involving patients in decision-making, in actual decision-making, really means to relate to the patient. And this is also something that doctors need to learn better. So this is one of the reasons why we have a program on communication in healthcare in Austria. And we offer this program also to oncologists, and it's very well received, and they find it very worthwhile to learn to communicate in a patient-centered way and to listen to their patients and to get better relationships and to get better joint decisions. And it really needs investments in communication, actually, which brings me back to the question that was raised before. Digital and or other aspects what is the role of digital care actually in palliative care? And I think there are good aspects where digital can come in. Tessa mentioned before how important it is to have access to your own data and to understand this data, but that the data are often not in a good format. And if we, for example, have good tools, artificial intelligence tools, for example, they can transfer medical records and coded disease codes and things like that into understandable language, and into, for example, put the medical record into an understandable plain language letter that the patient can take away and get meaningful insights from. So this is something where AI, for example, really can be of importance, whereas communication, of course, is also very, very important in many other aspects of palliative care.
Thank you. Thank you very much, Christina. I'm sorry for neglecting you. Stay on screen. So this is a request to the colleagues in the back. Stay on screen and do raise your physical hand up if you really want to come in, and I'll make sure to see you faster. Elizabeth, you had your hand up for your microphone up for a while. Come in briefly before we,
Yeah, just an observation also based on what you said about perhaps the difference between palliative care and oncology, because it's rather cynical to observe that apparently only when it comes to end of life, a patient is seen as a person, as the opposite as a disease area, because indeed that I also know from first-hand indeed that it's very much focuses on the treatment. And if you then also as a family member come in and ask about treatment options, you get the answer, why do you want to know? Well, I care, you know? And I think therefore, and that brings me again at the policy level, also one of the recommendations that we have done in our publication is that building capacity is very important, because doctors do not always seem to realize that even though I think it is helpful and really beneficial for a patient at the end of the road to have a multidisciplinary team where you have different expertise involved, how they communicate the results or the outcomes or the analysis of everything that's being discussed there to a patient, that requires a skill set that not every doctor has. So we also indeed recommended collective and collaborative training programs and workshops for healthcare professionals where these things can be discussed.
Thank you.
I also think, that we need to
No, go for it. Go for it.
understand the realities of how these multidisciplinary teams work. Because believe me, I've found out. And they're under high pressure. Okay, they're processing 50 patients, maybe, I don't know, 40 in an afternoon. They have very short time. They shove up the scans. What do you think? Yeah, well, could we do this? Well, yeah, maybe. It might be a bit risky. And then the people who are most interventionists very often are the ones who are most confident, speak out and suggest things, where other people who sit back and think, I wonder if that's really in the interests of that patient. You know, how much will it affect their quality of life? The decisions and the debate can be very nuanced, and yet you get this ex cathedra statement from a team, and you feel as if everything about you has been fully considered, but all they've seen is your scan. They don't actually know about you as a person, about what your goals are. I mean, the work of Al Molly says that, if you misdiagnose a patient's preferences, it's as bad as misdiagnosing their disease. And I think we need to think about that.
I think there are so many fascinating elements, and I think at least I realized we have 10 minutes left for the entirety of the panel. We haven't had any questions from the floor in the room yet. We could keep on going like this. Yes, and I know we do have questions from the room. I just want to bring us back a second to the digitalization element, which is like at least the point from which we started in the panel. And I've heard a number of different areas of application, from Christina just mentioning AI that could facilitate the efficiency, at least for some of the components of care that then would provide perhaps more time for the actual carers, professionals, to spend with patients, from Tessa talking about access to her health record, good access to a good version of her health record, but also an online resource that could facilitate shared decision-making, to platforms that could support caregivers and apps, to platforms that could support professionals. So all of these bits have come in the discussion. We won't have time to pick all of them up, but I think please do think in the panel if there are things that we've left out that we haven't mentioned at all in the digital arena, where we might want to put them on the table just so that we don't forget them. I'll take how many questions, points? Ooh, okay. Right, so what we're going to do, in full deviation from what we were planning to do, is we're going to take the 4 points that I just counted from the ground, and then we're going to come back for a closing round of comments from each of you, reflecting on some of the things that we will hear from the ground, and bringing us your Monday morning to-do list for the people in power, whoever that may be, depending on who you are. All right, so 4 points, starting from the front and going back, because that's easier for me.
Thank you very much. I'm a professor of psychology and the president of the Austrian Society of Psychologists. I just want to ask, in Austria we do have psycho-oncologists in the tumor boards. Is this European-wide now the issue? Is this done? And what do you think about the benefit of it? Thank you very much.
Thank you as well. So psycho-oncology and linked to palliative care. Yes, Pooja.
Hi, I'm Pooja Jha, Editor-in-Chief, The Lancet Regional Health Europe. And I want to understand the way spiritual care is integrated in palliative care. And this I'm asking out of great sense of responsibility from data. And if I can quote a publication from JAMA last year, a systematic review that found that people with serious illness, 50 to 96% of people desired spiritual care. And in a paper we published last year at the Lancet Regional Health Europe, it was a Danish study where we found that 82% of people desired spiritual care. And these are common people. So, perhaps spiritual care is something that can be digitized. And I want to mention that spiritual care doesn't mean being religious. There are various forms of spiritual care, and you don't have to be religious to seek spiritual care. So I think this is something that can be and perhaps should be integrated because there is data-driven need for it. Thank you.
Thank you very much. This is another add-on to the to-do list. All right. Do keep some things to discuss over coffee after the session.
Yeah. Thank you very much for the very insightful discussion. I have a question with regards to ethical aspects of AI, specifically in palliative care. Of course, we understand that AI is an emerging, I would say, like already emerged thing, and of course it is unavoidable. But I need to know, like, your opinions. How can we balance between encouraging innovations or digitalizations, specifically in palliative care, while considering ethical aspects, including patients' autonomy, patients' dignity, privacy, considering that they're being at the very sensitive stage of their lives, or I would say at the end of their lives. So what is your opinion on this regard? Thank you very much.
Thank you as well. We have one last point. I know there is more, but I only counted 4 when I asked in the beginning, so I'm not going to take the very last one. My apologies. We really don't have time.
Thank you very much. I'm Robin from the LSE, and there was a lot of discussion about building health literacy, building digital literacy, both in this panel and in other panels. And I question, why are we waiting until citizens turn patients to start investing in that, by and large? Are there not elements of that that we can already take care of before a patient or before a disease trajectory or a patient journey begins? So to not burden a patient with both a diagnosis, a treatment, and a whole bunch of stuff that they have to learn on top of that.
Thank you very much, Robin. So, final point. I will pass the hot potato, which will be the first response, to Elizabeth, because you've been the one who has the least time to talk until now. So, again. So we come to you in a moment. I think we go to Christina afterwards, followed by Fiona, followed by Diana, and we end with Tessa, if that's okay.
Yeah.
Very briefly.
Yes. Thank you. I'm Domingo from Spain. I'm a medical oncologist, those that we are treating patients and seeing them. And I think, I wonder if digitalization is also a palliative tool for the problem that we have, that is a problem with the workforce also, and the amount of patients that we need to treat, that sometimes we have to use that. So is digitalization a palliative tool? Or, because I like to make all what you have seen. I love being with patients, but when you have 40 patients in a morning, how we can do that?
Okay, I think this links perhaps to what Christina was saying about AI and improving the efficiency of processes, right? So this was one of the elements that we already had on the list, seconded, and something to think about. Elizabeth, hardest job, first response.
Exactly, and especially in a very short time, I believe, because I see the clock ticking.
Short time,
I think my recommendation really would be to develop the notion of data stewardship more for patients, so that indeed there is more clarity about how patients' data is used, also how it's reused, because that's an element that we even haven't touched upon. I think the reuse of data and also who owns my data, I think these are vital questions. And I think also in light of what you mentioned at some point, the gender element, because the quality of data is another element that patients and citizens at large, I think, should be concerned about, because we know that the current data being used for healthcare systems, but also for our societies, is often just based on, you know, white male Caucasians and not very inclusive, neither for women or for other groups with a more diversity background. So in that respect, I think there's a lot to learn. Even from different parts of the world. I think it's very important, especially at European level, where oftentimes we would say that topics like patient's perspective, let alone palliative care, where I think there's also a lot of cultural differences between countries, how different cultures approach that topic. But still, I think there is a lot to learn how different countries deal with these issues. So I would hope that also in the next 5 years, that element plays a role, even at European level.
So element of digitalization, data stewardship, particular link to the area of challenge and sensitivity around palliative care. Very well taken. Not just the opportunity, but also the challenges, gender aspect, different elements within our society. Christina, over to you.
Yes, thank you. First of all, I would like to say that the concept of psycho-oncology is very important in the Austrian Cancer Framework Program. Thanks, Beate, for the question. And I would like to pick up the question on health literacy from the floor, whether we can do more before somebody turns a patient. I'm afraid it doesn't work like that, because think about learning anything like a language, for example. If you do not practice the language, you will easily forget, and you will not be able to recapitulate or to remember. So you just learn what you need, actually. There are some basics, of course, that we can teach to children in schools or so on, but actually what you need when you're in a specific patient situation, I'm afraid you have to learn it there. And therefore, the healthcare system has to be ready to teach it then to you when you really need it. What we can do before is teaching people and citizens the skills to deal with information and to distinguish good information from bad information. This is something that we can do before, but not the actual stuff.
Okay, thank you very much. Very clear, and also clear agenda point for you, Christina, but also for other policymakers in other countries, linked to also what Elizabeth was just saying. Fiona, shall we come to you?
Sure. Any particular aspect you want me to?
It's the last time you get to speak, so whichever element you would like to highlight, go for it.
So in terms of pastoral care, spiritual care, existential care, that is a cornerstone. It's one of the 4 cornerstones of palliative care. And all of the patients who pass through our service get access to, should they choose to meeting with a palliative care clinician. All of our other non-specialist palliative care clinicians are trained in screening for palliative or pastoral care wellness, and they do deliver care through telehealth in Ireland. AI, you know, in our population, we are also doing some research at the moment using AI, deep machine learning around the use of patient-reported outcome measures and other factors that influence how quickly and reasonably and rightly and correctly that our finite resource can respond to need in the community. And we're using prescriptive and analytics as well to kind of layer in our available resource on a given day to layer in the roads and the road conditions and how people will get there, to improve access, to improve efficiencies. And we've done extensive stakeholder engagement in relation to that, including a Voices for Care forum that sits within our All-Ireland Institute of Hospice and Palliative Care, that has a panel of patients who review protocols like this and kind of give their view on what more for patient input needs to happen there. That's very embryonic in its stage, but I mean, we're years into this. It's really complex work, and ethically what we don't want to embed in are kind of more embedded inherent biases, but now to propagate them at scale through the use of AI. So we're very aware. We've an ethicist involved, we've informatics specialists involved, palliative care clinicians, and patients and carers.
Thank you. And if you had one imperative for Monday morning for those who make the decisions about what to do,
I would call for a new bravery in this space. It's brave to innovate in the area that is so human as palliative care, but it's very worthwhile. And it's brave, I think, as well, to identify when something isn't working and stopping it and changing it. And I would like to see that type of work and time incentivised and validated for clinicians particularly to be engaging in it, because success can also be contemplative reflection around what has not worked, and we need our research publications to balance up and publish what doesn't work in the same way as they publish what does work, because there's huge nuanced learning that can happen from that. And I think there's real safety in transparency around what doesn't work in digitalisation of this really vulnerable but important human space.
Yeah. Before, just 1 second, I think that links very nicely, the notion that you bring in with making sure that the system is resourced in a way that allows you to actually do that, links nicely with a comment that we had from the floor about how can we actually provide that service when we have workforce constraints, when we know we have so many patients. So it's both trying to leveraging it for improving the efficiency, but also really ensuring, and this is for policymakers, and I keep picking on Christina because she's a representative here from the ministry, but this of course goes for everyone, that when you think about how you resource the system that you hope will transform for the better, this space in everyday practice is something that you really need to consider. Diana, you were ready.
Just very quickly, I want to start on the point with spirituality, because coming from a former communist and widely Orthodox country, we can see that many times patients, when they feel hopeless, they're trying to, go to other, complementary therapies, religion, and so on. And I think that it is also important to have an open dialogue with your healthcare professional and actually explain to them that you are actually keen to, do that shift in your palliative care, because if not, what can it? I mean, people are trying to do that, so let's keep an open dialogue. And you were talking about the imperative point that for the Monday morning, and I'm insisting on seeing exactly what your resources already are in a system, see what works, what doesn't, and only after that come with complementary, tools, like we mentioned earlier, digital tools and so on. So just make the best out of the resources that are already there. We don't need a whole, system shift.
Okay, but we need to evaluate whatever shift we make to make sure that it's actually working in the way that we want it to be working. Tessa, you have the final floor for reflections. This is a lot from many directions, I think. But we are closing a panel about the potential for digitalization in palliative care and what we need to do and what we need to be careful about. So perhaps give us your key takeaway messages.
Well, I think it's around this. We've talked a lot about it here at Gaston. It's co-creation, isn't it? It's co-creation of the technology, the services, co-design, and I think it steps back even further from that. I think we've got to co-create the research agenda. It's which is beginning to be done in clinical medicine, because there's a wide disconnect between what doctors think are the important unanswered questions. And if you go to the patients, they have a completely different set of questions. And the great thing about there's a model called the James Lind Alliance Priority Setting Partnerships, is you get everybody in a room. You get the researchers, the clinicians, the patients, the carers, everyone who's got a dog in this fight. and they fight like rats in a sack until they come out and agree after a long, sweaty day what the top priority unanswered questions are. So you're sort of really starting more from the top. I think that's important. And I think we need to take, we need to sort of really hear and listen better and use the massive amount of patient experience feedback data to actually do something with it. And we need to change our systems in such that they can change, because very often people are overwhelmed with this stuff, but they're not using it constructively to inform change. We've got to learn together much better about where value lies in the treatment and services we provide.
Thank you very much. I think this chimes well with all that we've heard. I think what I take away from all the final statements is there is a need for an overall understanding of where the potential is, where the pitfalls are, and then a prioritization process that involves everyone who has a stake, right? And that ensures that we have not only co-created solutions, but also a collaborative evaluation moving forward to make sure that we actually deliver on what matters and what brings value. We have to end here because we're already a couple of minutes too late. At least as far as I'm concerned, I could have stayed much longer and talked with you all. So I hope you will stay a bit and have coffee with the rest of us and with the participants here. A big thank you to all of you who brought your points in. A big thank you to everyone on Slido. I know there is a lot going on that we haven't had a chance to come back with, but we have all your points and all your questions, and we'll take a look. We also have an evaluation form on Slido for the session, so please, if you have a moment, give us your feedback on what you thought. We take all the insights with us, and we will keep working and hopefully have a better solution moving forward. Thank you all very, very much for coming.